Hello, and welcome to this special event. My name is Adam Leventhal. I'm director of the University of Southern California Institute for Addiction Science. And this event, hosted by the University of Southern California, that you're tuning into will feature an expert panel, including Dr. Raul Gupta, the director of the National Drug Control Policy and lead of the Office of National Drug Control Policy of the White House of the United States. Dr. Gupta will be joined by two USC experts. This webinar is being co-hosted by the USC Institute for Addiction Science and the Leonard Schaeffer Center for Health Policy and Economics. And both of our institutes are cross-cutting interdisciplinary units, which bring people together from different types of disciplines across our university to combat the addiction crisis and address critical health policy issues. And one of our missions is to engage with the community and the public and stakeholders, which is why you're here today. A little bit about today's event. After I introduce Dr. Gupta, he will make some opening remarks, and then he will be joined by our other expert panelists, Drs. Liccardo Pacula and Dr. Blumenthal. And then they'll have a chance to react to Dr. Gupta's initial comments, and then we'll field questions from the audience. So if you have questions, please put them in the chat to the host and panelists, and we will do our best, if there's time at the end, to field a few questions. And before I begin, I just want to take a moment to address the importance of this issue. As many of you know, the addiction crisis is at amongst one of its worst points in our country's history. Policy is one of the most critical ways of quickly and effectively combating addiction in our community and in our country. And that's why we're here today. And the addiction scientific and policy community has never been more mobilized than they are right now. And this is highly exemplified by Dr. Gupta and what his office within the Biden-Harris administration is doing. That's very exciting, that will help combat this critical issue. So with that, let me introduce Dr. Gupta. I'm honored to explain to you that Dr. Gupta is the first medical doctor to serve as the director of the National Drug Control Policy and to lead the Office of National Drug Control Policy, a component of the Executive Office of the President. This office coordinates the nation's $40 billion drug budget and federal policies, including prevention, harm reduction, treatment, recovery, support, and supply reduction. Through his work as a physician, a state and local leader, an educator, and a senior leader of a national nonprofit organization, Dr. Gupta has dedicated his career to improving public health and public safety. As a board-certified internist, he's been practicing as a primary care physician for more than 25 years. He's served in practice in public health in towns as small as 1,900 residents and cities as large as 25 million. He's served as local public health official and as the West Virginia Health Commissioner under two governors, where he brought together public health, law enforcement, healthcare, faith-based, business, and other community partners to solve local problems in novel and innovative ways. As the state's chief health officer, Dr. Gupta led the opioid crisis response and launched a number of pioneering public health initiatives, including the Neonatal Abstinence Syndrome Birth Scope program to identify high-risk infants, and the groundbreaking statewide social autopsy, which examined the lives of overdose victims to determine the factors that led to their deaths and what services could have prevented their deaths. This led the state to expand access to Naloxone, as well as treatment services, including those for incarcerated individuals, to save lives and to help people transition back into the community. He was also instrumental in expanding state-of-the-art comprehensive and integrative medical and behavioral health programs for pregnant and postpartum women. His lifelong commitment to educating the next generation of physicians and policymakers has led him to hold academic appointments throughout his career, including a clinical professor in the Department of Medicine at Georgetown University School of Medicine, and as a visiting faculty at the Harvard University T.H. Chan School of Public Health. Additionally, his passion for global health led him to join the March of Dimes as Chief Medical and Health Officer and Senior Vice President, where he provided strategic oversight for the organization's domestic and global medical and public health efforts. Dr. Gupta is a national and global thought leader and driver of innovative public policies and practice of what he preaches. He's a buprenorphine waivered practitioner, providing medication-assisted treatment for people with opioid use disorder. He's been recognized for his career public service by the American Medical Association, the American Public Health Association, by Governing Magazine, which named him the Public Health Official of the Year in 2018, and the Pulitzer Prize-winning Charleston Gazette Mail named him as West Virginian of the Year in 2017 for his service. He's the son of an Indian diplomat. Raul was born in India, grew up in the suburbs of DC, and at age 21, he completed medical school at University of Delhi, followed by specialty training in pulmonary medicine. He earned a master's degree in public health from University of Alabama, Birmingham, a global master's of business administration degree from the London School of Business and Finance. He's married to Dr. Seema Gupta, a physician in the Veterans Administration for over a decade, and they're proud parents of identical twin sons, Arka and Drew. A well-rounded man. So let me toss this over. It's my honor to introduce Dr. Raul Gupta.
Thank you, Adam, and thank you for that nice, well-rounded introduction. I appreciate it very much. And thank you to my colleagues here on the panel, Dr. Pakula and Dr. Blumenthal, sorry about that. I appreciate the Schaeffer Center for inviting me over, as well as the Institute for Addiction Science. Today, I want to spend a few minutes talking to you about what we face when looking at the substance use disorder, overdoses, and the untreated addiction and drug trafficking that fuels them, and where we can go from here. As Adam mentioned, I have seen the overdose epidemic up close as a practicing physician for well over 2 decades. I've treated hundreds of patients with substance use disorders in rural and urban areas. I've seen patients make it through treatment and into long-term recovery. And also, I've seen patients succumb to their disease sometimes, unfortunately. So as a committed practitioner and a policymaker, I'm committed to doing everything I can to save lives. And I know that's why many of you are here as well. First, though, I'll add a little bit of what Adam mentioned about the White House Office of National Drug Control Policy. As you know, my office develops the President's National Drug Control Strategy and oversees the drug-related programs and $40+ billion budget, as was mentioned, of the 18 federal agencies that work in this space, spanning from public health to national security. Our team includes experts in all things drug policy, and we regularly bring folks on for additional expertise across federal government as well as academia, who typically join us for a 6 to 12-month rotation to ensure that our policies are comprehensive and well-rounded. So we have scientists, researchers, and medical professionals on our team, as well as leaders and public safety individuals with national security experience as well. So just know if you're out there, you're interested, we love to have you, and we love to look at that. So every day here, we're working at the intersection of public health and public safety. That's really where the solutions lie. And, the fact of the matter is that our mission has never really been more critical than it is now. If you know the CDC's latest data, which tracks predicted deaths through October of 21, we've lost more than 105,000 people in this country in a 12-month period. And 3 out of 4 of these deaths involve opioids, mostly illicit fentanyl. Now, fentanyl can be very powerful in small amounts, which makes it profitable to criminal organizations and easier to traffic. And that's exactly what makes it so deadly. Now, we're seeing more fentanyl sold on the street as counterfeit pills, often indistinguishable from real products like OxyContin and Xanax and others. But we're also seeing increases in deaths involving stimulants like cocaine and psychostimulants like methamphetamine. And oftentimes it's because illicit fentanyl is mixed in. Now, most of these deaths involve people between 25 and 54 years of age, so these are people in prime of their lives. So on an average, we're losing an American to an overdose every 5 minutes around the clock. These are friends and family members. These are coworkers and students. These are healthcare providers and scientists that we're losing around the clock. Amongst those we're losing are also physicians and other medical providers. To me, it's heartbreaking, and frankly, it's unacceptable because so many of these deaths were preventable. And that is why I bring you greetings from the White House, because President Biden's unity agenda is so important. As you may have heard, during his State of the Union address, President Biden announced this new agenda, and first on that list was the overdose epidemic, followed by the mental health crisis that our nation is facing. And the president recognized the interplay between the two. And of course, he's right. Specifically, he said, let's beat the opioid epidemic. And there's so much more we can do about prevention, treatment, harm reduction, and recovery. We need to look at getting rid of outdated rules that stop doctors from prescribing treatments. And we need to look at parity. And the fact is that, let me mention a few things that we're already doing or have been doing so you are aware. Since day one, President Biden has focused on doing everything we can to save lives. A big part of our strategy to save lives is focused on two main drivers or big drivers of this epidemic. So it's untreated addiction and drug trafficking profits. So we're expanding the care for untreated addiction and hitting criminal organizations where it hurts them the most, as their wallets. And because of what we've been learning about science of addiction, we're really changing how we help people who use drugs. We're taking new initiatives to meet people where they are with high quality harm reduction services. For the first time, the federal government is moving forward with and endorsing harm reduction services. And we're removing legal policy and financial barriers to effective treatment for addiction. And we're focusing on advancing racial equity, which is a long-standing problem in drug policy in terms of both healthcare and criminal justice. We've taken a number of these steps that I want to mention to you, just a few of these. We made it easier for more healthcare providers to prescribe buprenorphine to patients with opioid use disorder. So unlike me, who had to go through a complex process of obtaining that waiver, thousands of providers have now signed up already to just do that within the last few months without having to go through that complex process. But we need more. We need more providers to do that across the country. We've also extended the pandemic rule changes that allow people with OUD or opioid use disorder that can begin treatment by telehealth, including phone consultation. And some patients receiving methadone can take medications home now instead of having to visit a clinic every single day. We've also revised regulations to allow treatment providers to operate mobile methadone vans. What that means is that brings evidence-based treatment to rural populations, underserved populations, as well as incarcerated populations. So we're making progress, but there's so much more we need to be doing. This month later, we'll be releasing the President's inaugural National Drug Control Strategy, which is going to include evidence-based prevention. It's going to include harm reduction, treatment, and recovery support services, but also how do we work to reduce the supply of illicit substances in our communities. As we release that, my top priorities this year include 4 pillars that can help us save lives right now in short term and the long term. These 4 are expanding access to Naloxone, expanding access to evidence-based treatment so people get the help they need when they need it, Third is improving overdose data collection, especially for non-fatal overdoses. And the last one is going after drug traffickers' profits, so we can reduce the supply of drugs entering our community. So let me just talk a little bit about each one. For naloxone, every overdose is a cry for help. And we need to be making sure that medications such as naloxone, which is the antidote or opioid overdose reversal medication, that we can get easier access across communities. If we do that, we will save lives quickly. As I mentioned, 3 out of 4 of these deaths that we know, and that's 79,000 deaths, that when I say that, it's because of opioid, one type or the other. And naloxone is one of the proven harm reduction interventions that our administration is working with states to expand. Others also include fentanyl test strips and making sure that people can detect fentanyl in their drugs, and student service programs, which have a proven track record of reducing spread of diseases such as HIV and hepatitis. And also they increase access to health care and treatment. They improve public safety and reduce costs to society. The fact of the matter is, though, naloxone is inconsistently available because of various policy barriers, legal barriers, and cost barriers. Most of the naloxone that I've used has been in the setting of an emergency room or a hospital or a clinic, but that's not where overdoses are happening. They're happening at home. They're happening in malls. They're happening at gas stations, restrooms. And we need to make sure that we provide the ability to provide naloxone all across. And that's why one of the things we've done is we produce state model laws on naloxone, because the fact is today, a patient's or person's zip code determines whether they get to live or die from an overdose. And that just shouldn't be acceptable to any one of us. So access these proven life-saving interventions like naloxone, fentanyl test strips, and student service program should not depend on where you live. Now, these strategies do have bipartisan support, so this is an opportunity for change. Now, we also released earlier late last month, actually, we released something called a deflection model law. The deflection model law allows first responders, including EMTs, police and others, to divert individuals with substance use disorders or mental health conditions to community-based pathways to treatment and recovery support services and housing and so many other services rather than incarcerate them. This is our view and version of making sure that we are providing options to people before the option to incarceration. We are focused on some of these activities in terms of harm reduction. Second piece this brings me to is, what do you do after you provide naloxone? When you provide people to these settings? Well, we have to expand the quality treatment, including medication for opioid use disorder. We know that overwhelming majority of people, 90% of people who need specialty treatment for illicit drug use disorder in 2020 did not receive it, 90%. There was a time when I could prescribe opioids for pain in rural Alabama and West Virginia, but could not prescribe treatment for opioid use disorder and had to refer people to specialty care, sometimes hours away. And you know what happens when that happens? People just don't go. They have to worry about their job. They have to worry about childcare, gas money, all kinds of issues. And when they don't go, you know what happens? They come back in the emergency room as an overdose. Sometimes they get to live and sometimes they don't. And that's the actual aspect we're trying to avoid. So we need to build a system of care that proactively seeks, diagnoses, and treats people who need it rather than waiting until they come to the criminal justice system or present with an overdose. Now, the third priority or third pillar is data. We also need to know what is happening at local level so we can make better policy decisions. I recently met with Maine Governor Janet Mills, who told me that in Maine, overdose deaths comprise just 7% of all overdoses. What that means to me is that we have a chance to reach 93 out of 100 people in Maine who overdose and survive before they experience another and potentially fatal overdose. So imagine how many people are using illicit substances, including fentanyl. Imagine reaching them after their first overdose before it's too late, and imagine connecting them to treatment. So we need to get this information from EHRs, electronic health records, back to the primary care providers and others. And that's not happening today. Lastly, illicit finance. We have to attack, and we are attacking, a key enabler of drug trafficking, which is illicit finance networks. We're going after criminal organizations' profits with the new sanction powers the president has recently ordered, as well as law enforcement actions on illicit finance. Going after illicit finance activities, I believe, serves two purposes. First, it disrupts the flow of financial benefit to individuals involved in the illicit drug industry, reducing the incentives to engage in drug trafficking by eroding the profitability. And secondly, it denies the drug producers and traffickers the operating capital they need to sustain their illicit activities. The bottom line is this: if it's easier to get illicit drugs in America than it is to get treatment, we're never going to be able to bend the curve on overdoses. And as Adam mentioned, we're amongst some of the most challenging periods in our nation's history. We know that substance use disorder doesn't occur in a vacuum, and neither does treating it. There's so many risk factors and circumstances that can lead to people developing substance use disorder, from housing to employment to adverse childhood experiences and stigma and so much more. And that's exactly why President Biden's agenda is broader than addressing drug use and drug trafficking. We're also addressing factors that affect substance use disorder, including child poverty, employment, and economic opportunity, so people have a chance to reach their full potential. Our success as a country in addressing addiction overdose is largely going to depend on whether we can translate good science and research into effective policy and action. I want us to work together to promote solutions that will save lives. And I believe that each of you here today can play a role in this too. Whether you're pursuing careers in healthcare, research, business, government, education, you all can play a role. You can help challenge the stigma and biases that continue to stand in the way of science and compassion when it comes to addiction and drug use. You can help make sure that more public and private organizations make decisions based on science of addiction when it comes to how they engage their employees, their customers, and their members of their communities. You can promote evidence-based harm reduction strategies. You can advocate for state laws that make it easier to keep people alive and support them in treatment and recovery. I know that you can create the change that our country needs. And I want you to know that I will be from this office doing all I can to support your efforts. So thank you for listening to me, and I'm happy to engage in the discussion as well. So I'll turn it back to you, Adam.
Thank you, Dr. Gupta, for your compelling comments and outlining of this critical issue and how multifaceted the causes and the solutions are. So I'm very pleased to welcome my two colleagues, Professor Rosalie Liccardo-Pacula, who's an internationally recognized addiction health economist, and the Elizabeth Garrett Chair in Health Policy, Economics, and Law in the USC Price School of Public Policy, a senior scientist within the Schaeffer Center, and co-leader of addiction policy research within the Institute for Addiction Science, as well as Dr. Ricky Bluthenthal, who's an award-winning sociologist and public health scientist, professor of population public health sciences, associate dean of social justice of USC Keck School of Medicine, and director of community engagement at USC's Institute for Addiction Science. I'll turn it over to Dr. Pacula.
Thank you so much, Adam. And first, let me say thank you, Dr. Gupta. It is really such a pleasure to have you here. And I was so excited hearing your remarks. They're very, very refreshing and exhilarating to finally have someone in the office. I mean, we've had changes in the past that were small changes, but your understanding as a practicing physician, I think, brings tremendous insight into really how to address the problem of addiction policy from a medical and healthcare perspective. And I was really grateful to hear so many of your remarks. I am hoping, and we're going to do this as a discussion because I know my colleague Ricky has got a lot to say as well. But one of the things I was really hoping that I could ask you to expand a bit more on, having studied myself some of the issues with evidence-based treatment and trying to provide access to it, I think two real barriers beyond some of the state laws that have limited access to some of the evidence-based treatment is the fact that it's really hard for consumers, for parents, for loved ones to find and identify good, effective treatment facilities and differentiate them from the poor ones, as well as provide the comorbid services, because many people struggling with addiction are also suffering, as you mentioned, with mental health, with serious chronic pain, with PTSD and other conditions. And because of how a lot of our addiction treatment centers are set up, they're not really set up as well to meet the comorbid needs of these patients. I'd love to get your thoughts on what ONDCP thinks it can do to try to help address this.
Thank you, Dr. Picola. I think it's an important piece of where we've been to where we are today and where we need to go. I remember that in the state of West Virginia, when we used to publish the data of treatment centers, we would often take an Excel sheet or even worse, scan a list of Word document and put that up and submit that to SAMHSA to publish. And that's all we would get. This is just a few years ago, so it's not. And now today we're looking at, and these were not dynamic environments. That would be once a year, literally. And now we're getting much more dynamic about it. But at the same time, as I mentioned, we really don't have an addiction treatment infrastructure, to be frank. And I think as we build the infrastructure for this, we need to have that data sets right behind it. So we need to have the ability to provide support to people where, when they need it, in a way that doesn't break an arm and a leg to the family that's taking care of people. So what I mean by that is that's exactly where everything from expansion of Medicaid, ACA coverage, to making sure that treatment centers are able to provide that treatment and have that capacity to provide that, both inpatient and outpatient, but also then for people to have the ability and awareness of where they are. We're working very closely with our partners at HHS and SAMHSA to be able to do that. We're making progress, long way to go, but that's going to be one of the important things is, today where we are basically in a treat them and street them mode, generally speaking, across the nation. Somebody comes in with overdose. Many of our facilities do not have the ability and resources to treat an overdose as a cry for help, as a medical emergency. We often provide the treatment. I've been there and done that, and send people off. What we need to be doing is taking every opportunity of a non-fatal overdose as an opportunity to connect people to treatment and link them to treatment in that community. That's exactly why data and following that is one of my 4 pillars, and I think we have to hold ourselves as a healthcare system more accountable, but that will only happen if we start to measure that data.
Thank you for that, and really appreciate you speaking with our group today. And I just want to highlight there are a few things you said in particular that I liked. One being, of course, making treatment easier to get than illicit substances, which should really be one of our North Stars. In terms of harm reduction, which I think your office is now going to be most noted for in terms of making change at the federal level, there are a variety of other approaches in the harm reduction realm that are evidence-based that have not seen the implementation in the U.S. that some of us who follow the literature would have expected. Those include safer consumption sites, 2 of which are now operating in New York. There's an unsanctioned one that's operating somewhere in the United States, the results of which have been highlighted in, I think, 5 or 6 publications and shown to be highly effective. What can your office do to push for these kinds of approaches to overdose prevention, given the emergency, right? No one's ever died in a drug consumption site And it seems a tragedy that we haven't implemented them more widely in the United States.
Thank you, Dr. Blumenthal. So this is a really important piece, and let's define the context. Today we're dealing with the context of 105,000 overdoses, deaths. We're dealing with 79,000 of which are related to opioids, deaths. And we currently, within that harm reduction confines, as you correctly identified, we've identified for the first time in the history of this nation for the federal government to support harm reduction strategy first. Secondly, specifically, that strategy is intended to save the most number of lives possible. So that's where naloxone comes in, that's where fentanyl test strips comes in, and that's where certain service programs come in. So as you correctly pointed out, the reason people haven't died for most practical purposes in an overdose prevention site is because of naloxone, because people are able to get the antidote widely available. And we want to make sure that, first of all, that everyone across the country has that same opportunity. Secondly, as the data becomes available, and there's a really good paper on this from NIDA that Congress had asked NIDA, the National Institute of Drug Abuse, to look at that and actually evaluate strategies that are emerging strategies across the globe, and study that and provide us the sort of feedback of what does need to happen in the United States in order to move forward. There's a really good set of recommendations made. What I have said, and I will continue to say this, is that we are really interested in the research that goes behind understanding the clinical effectiveness of emerging harm reduction practices across the nation. So we remain open. Look, the bottom line is this: we have, an American dying every 5 minutes. So we cannot afford to not be open to looking at the science that goes behind and the research that goes behind any and every strategy. And then we have to look at, okay, what can be scaled up to the point. Right now, we do have focus on these three elements I mentioned, but we are open to looking at the research into these emerging, the clinical effectiveness of these emerging harm reduction practices.
Thank you very much for that. Let me just follow up with a question that's a little bit different, but kind of related to this topic in a tangential way, which is, and you have my sympathies in your office. I mean, there isn't a national drug problem, right? There's a problem in San Francisco and a different one in New York, and in a place like Los Angeles where I work, there are probably a dozen different milieus where illicit substances are causing harm to people, and you really need different kinds of approaches to addressing each of those given the parameters of the specific drugs involved. So I just wonder what is the role of your office in trying to help regions, cities, local groups address the diversity of substance use challenges that we face as a country?
That's a really good question, and a really important one at that. So when we see various problems, and exactly right, when we put the data together, it's one thing, but epidemiologically, you have to look at data where it's at. So we have two kinds of challenges. One, we really don't have as good an understanding of what those substances, local substances are where. We always tend to, as a system, as a country, kind of track them, right? It's always after the effect, after the scene. We get CDC data that's, obviously a few months late. We got all the mortality data that comes from medical examiner's office multiple months late. I used to be head of that in West Virginia. So what we need is, on one hand, and that's where the data piece goes, we need some real-time tracking of understanding what those challenges are happening. So that's one piece. The second is there are some clear challenges, like meth, for example, which we do not have really good pharmaceutical treatment options for. So one of the things we're really happy for and glad for is, and when I spoke with the CMS administrator, I mentioned that I'm really happy that we're putting, for example, in California, an 1115 waiver process that allows contingency management, these promising treatment opportunities that are available now, looking at, obviously, to an evaluation behind it, to see what happens so it can look as a model for other states to follow. So one of the things we want to do is encourage those evidence-based practices for other beyond naloxone, other aspects of substance use. Yet, and that's a great promising thing. And there are other states that are also putting in their 1115 waivers, and we're happy about that. Yet we still have a gap where we are not able to in real time figure out the polysubstance use nature of each individual locality, as well as what is dominating. And the reason that's important is because when trends change, we're always behind the curve. And I've been in this business too long to see that, and we need to figure out how do we get ahead of the curve.
That actually brings me to one of the main questions I was hoping that you might be able to address. And I was, again, very encouraged by the amount of emphasis you place on data collection. One of the things that has unfortunately been happening over the last several years is a reduction in the available information that we've had of the problems, not just nationally, but locally through the loss of the OSD drug abuse monitoring program and the drug abuse warning network program that did have localized samples. Is ONDCP is one of the goals as you're emphasizing data collection? I know that NDUS has emerged. I know several of us researchers are trying to do what we can to develop some localized systems with local hospital and poison call data and clinical data, but is ONDCP have an agenda to try to fill in some of these gaps that are now gone?
Yes, thank you for that question. Another important question. One of the first things in the office when I came in terms of data, we were looking for those gaps. We have stood up an interagency data working group. This is a brand new data working group that's working across federal government to figure out and look at the gaps on one hand. On the other hand, we are partnering to do what we can. For example, you would have seen publication just last week from one of the NIDA's funded folks to look at the 9 million plus pills that have fentanyl, that's Caesar data. So our NIDA is working closely with a high intensity drug trafficking area program, which is law enforcement side of this. The grant runs out of this office. And we're working together in sort of research way to figure out and publish that data. We are looking at new and nuanced ways to understand better, whether it's looking at things like sewage or the other aspects of what can we look at, sort of storm, the drainage water and other aspects to understand the prevalent substances. At the same time, I think one of the things we're looking at is the NHTSA data that looks at the 911 calls and across the country. We don't have a good case definition for beyond opioid overdose yet. So we're looking at the opioid overdose. We're looking at response times across the country for 911 systems. And we're looking at the administration of naloxone and other actions that may have happened. So we're developing a dashboard on that right now as we speak. And then we definitely want to have a much more system of surveillance, or you call it monitoring, or however, to have an understanding of very similar to or close to like we do for flu or COVID or other aspects. I mean, I often use COVID as an example of where the data can take us. But the fact of the matter is, we've not made a lot of progress in the last 20 years plus. And ability to understand what those drug patterns are, as well as the non-fatal overdoses.
Yeah, one of the things I can say as a researcher who's been very engaged in this activity for the ONDCP as well as independent projects is access to some of the most valuable data sets at the time in which they're most valuable, whether it's ARCOS on prescription opioid distribution at a local level, or National Survey on Drug Use or Health, which has representative samples at SMA levels. Those are very difficult to gain access to, and data from law enforcement through StarLIMS has been impossible to reach. And it seems like that now is the time when we need greater access to those limited data sources we do have to help better understand how to make use of it and what we can learn from it.
Thank you. And I will commit to you that I'm working very closely with our DEA administrator, who is very public health minded and understands the value of data, as well as our partners at HHS to figure out, as well as the HIDA programs, to figure out how to connect. Because I think the real sort of secret sauce here is to be able to connect researchers with both the data from the treatment side, but also from law enforcement side as well.
Okay, well, this is a wonderful discussion. So now I'm thinking that we can open up to the audience questions. There's some interesting ones that have come in, and this one is a little bit of a shift. So now we're going to talk about cannabis. There's lots of discussion about legalization of cannabis, and what I would also add myself, commercialization of cannabis. And is ONDCP involved in talks with other federal agencies to monitor new product development, cannabis products, I think they mean, adverse events and impacts of these new markets? And what would you like to see set up, and how might the administration help make it happen? And this is particularly the case when we think about cannabis concentrates, which are essentially the fentanyl of cannabis. So we'd love to hear your opinions on that, Dr. Gupta, and then also Drs. Pakula and Blumenthal afterwards.
Great, thank you for that question. Just as a way of background, when I was a commissioner of health in West Virginia, the legislature passed a law to legalize medical cannabis and put that into my shop. And so I helped develop one of the most robust programs for medical cannabis in the state of West Virginia. One of the things we want to be in this administration is be guided by science and evidence. That's our true north, really. And what we're doing is we're looking at, obviously, where does the science take us in terms of the purpose of the use of cannabis, but also in terms of its impact on the racial justice aspect of it that it's been in the past. So we're looking at all of those sort of challenges moving forward in a way that's driven and sort of informed by good science and good data. So again, the partners is HHS, including NIDA, FDA, and others are those that are close to us, and we're continuing to have those discussions. Without being specific, we try to be proactive in some of these things to see where good science is, and we continue to monitor those.
I think that was well said, Dr. Gupta. I am aware of committee work groups, both at FDA and CDC, and then obviously a significant amount of NIDA research on the topic. And I think that it's being taken very seriously as a potential change, given there are proposals, and one just passed on Friday from the House to decriminalize cannabis. And the question is, to what extent do these agencies need to or should be involved in a potential regulatory framework should Congress decide to change the overall environment?
So if it's okay, I don't want to talk about cannabis right now. I'd like to move on to a different topic. Rachel Caesar asked in the chat, and I'm going to scroll this back to something you said, Dr. Gupta, about drug control policy as it relates to pregnant people. And in particular, you made an important point, I think, about the importance of featuring equity, health equity, in the policy development. And we know that there's been a lot of inequity in the application of drug control policy to pregnant women, and that has disproportionately impacted African American and Latinx women historically. And it also relates to the issue about childhood vulnerability moving forward even. So I'm just wondering, what's the role of your office in helping to reshape the conversation on that, so we have one that's strength-based and building up families rather than tearing them apart?
Oh, thank you. Such an important question, because that's the future for our country. That's the way I look at it. And it's not a coincidence that before this position, I was at March of Dimes, where the focus is maternal child health. And before that, worked a lot on this issue. So we know that maternal mortality in this country, as an example, is continuing to rise. And for Black women, you're about 3 to 5 times more likely to die as a result of childbirth. And even in that, about a third of that, if you look at postpartum piece, third is pregnancy, third is pre-antenatal, third is pregnancy, third is postpartum. And a good piece of that postpartum piece, for sure, is contributed by substance use disorder. So we know that there's a relationship there. What is important, as I've seen in my work and I continue to push, is that we need to make sure that the universal screening that's recommended by American College of Obstetricians and Gynecologists, ACOG, is followed up by making sure that there are proper referrals to treatment. And pregnant people do not feel the fear of punitive addressing in reaction to having a positive urine tract or a screen test. That's really important because when I was in West Virginia, one of my first trips to Huntington, West Virginia, I asked the OBGYNs there, why aren't you screening? They said, well, so what if we do? We don't have the treatment facilities available. So we did exactly that. We expanded from 2 to 18 sites in the state, something called Drug-Free Moms and Babies program, and allowed the investments to occur that provide care for pregnant people that not only improves the life of pregnant people, allows the children, the newborns to stay with the mom, which is the biggest stimulant, biggest reason for mom to follow up into treatment. And then it has additional things like increased breastfeeding rates, increase all kinds of benefits to society. And at the end of the day, the NAS rates. NAS improves as a result of that. So there's all kinds of benefits. Here, we do have a working group within agency, an agency working group that Dr. Stephen Patrick from Vanderbilt is leading, that is looking at specifically this issue. That how, and for us, he's doing this work as out of this office and leading the work on the opportunities and policy implications to improve the care of pregnant people. This will ultimately be one of those very important aspects of addressing racial equity as a result as well.
Great discussion. So we have another question coming in. The question asks, what are you doing to help patients who have either pain or addiction or both, whose doctors are arrested or otherwise stopped from prescribing and are currently left in withdrawal and without continuity of care?
That's a great insight question. When I was a commissioner in West Virginia, we saw that happening. And as a result, when these drug busts happen, quote unquote, of pain clinics, what happened as a result? What we saw happening was a question hits it right there, which is more people with chronic pain needs went either to the emergency room, on the street, or overdosed. Those are potentially the three outcomes. So we worked with our partners at federal agencies like DEA, United States Attorney's Office, to develop protocols to make sure that other community physicians were involved in the care of those individuals that were often denied that treatment because their primary physician was arrested. That's important strategy because providers often don't want to take on those patients because they see that they could get in trouble. For the state or other federal officials to be able to say, if you follow the rules, you will not get in trouble. That's an important piece. You will see, and I think there we've had an open comment period about the CDC's revised pain guidelines, chronic pain guidelines. That's going into the process. We are providing, obviously, our comments and technical assistance, working with our partners at CDC to make sure. It is very clear. We have a tendency in this nation to swing pendulums from one end to the other, and we need to get in the middle. It is very important to look at the needs of people with chronic pain and make sure that those needs are being addressed in a responsible manner and not deny them the treatment and all options, not just from, I'll say this from a physician standpoint, not just pharmaceutical, but also non-pharmaceutical options that often allow and need to be covered through insurance that allow those people to function and improve their quality of life.
I really appreciate that. I actually am of the mindset here that this is one of those things that if addiction and chronic pain were handled fully within the medical system, we would have a better way of enveloping those individuals and identifying how to channel those people. But because addiction treatment is being done outside of standard treatment facilities, even if they are by medical professionals, these people get lost in the system. And so I am one of the believers that think that if we do a better job of bringing what used to be the sister child of addiction treatment back into the medical treatment community fully, more integrated. Then identifying who these people are when there's an inappropriate doctor and getting them to another doctor who can meet their needs would be much more viable, because you have the healthcare systems who care about doing that. They get paid and reimbursed based off their ability to handle each patient in the clinically appropriate way, and they're incentivized to do that. And the patient can be treated more as a whole in terms of all their conditions. But this hasn't been, that's not even how we pay for a lot of substance abuse treatment today. We still do it through the block grant funds instead of through healthcare systems. So I think there does still need to be this kind of shift in acceptance of the condition. But as you say, Dr. Gupta, these are not easy patients to handle. And so if doctors are left with the decision of choosing which patients they want to take in, these are not going to be the ones that always are accepted, except for by a small group of doctors who have a very personal connection to these illnesses.
You know, if we are to look at people as human beings, then people with chronic pain also have other conditions like diabetes, like hypertension and others. So it goes back to treating people as human beings and with the dignity and the care. And that's where this all comes back. If we're looking at that perspective, then it's one individual with all of these conditions, and we should treat these conditions such as that we're treating the whole person. So thank you for those comments.
I'm realizing we could spend the rest of the day asking you questions. So it's hard to prioritize, but let me ask, I think this is a follow-up to something you said earlier. So you made the point that your office is now talking about harm reduction everywhere you go, which is a huge step. There was a question in the Q&A about the degree to which, and you've made an open invitation, so hopefully others will take it, the degree to which you're working directly with people who do harm reduction programs or in-service programs in your office or through working groups to make sure that you're getting access to the innovations that are happening in that space, maybe not on a daily basis, but pretty frequently, so that they can be integrated into national policy.
Thank you. We do have a group, stakeholders group of harm reduction coalition that we meet with frequently, both with our partners at SAMHSA, as well as we do as well. So we're very much grounded. We are continuously in contact with folks who are doing harm reduction. When I went to Miami recently, I met with Dr. Hansel Tukes out of University of Miami, who's running a great program there. And we discussed both some of the great outcomes as well as some of the challenges. For example, in having in the state legislature in Florida pass the law and the ability to expand harm reduction clinics across the state. So, it's a science and art, right? So it's an important piece that we are both staying in contact with all the innovations and other aspects that are happening, at the same time making sure that we are aware of that and trying to support both the existing pieces with the understanding, as I mentioned, I'll say it again, we have, I believe that the 79,000 people that passed because they didn't get naloxone on time, a majority of those should have been saved. And in each year we have, this is something that's happening every 5 minutes around the clock. It bothers me to no end to see that. And our priority has to be able to save lives first and foremost. So anyone and everyone who's doing that out there, we're trying to reach out and see what we can learn from them.
One of the things I didn't get a chance to raise earlier, and I see is coming up in the questions as well, how do we help the public understand that addiction is a chronic relapsing condition? And so while we may have success with some individuals very quickly, other individuals are going to take multiple episodes of treatment before it's effective. How do we discourage support for a health approach to this when people don't immediately see recovery as the quick final solution?
That's a great question too, and I think it has to go back to stigma. I think the stigma is probably the biggest enemy at par with the drug trafficking organizations of this problem. So one of the things that we're looking at is when you give somebody naloxone, I've used naloxone example, we don't have that same stigma when we administer somebody a first aid or CPR or AED device. Yet the naloxone people, some people will make judgment calls about administering naloxone. So I think some of the language has to change around this. The way we speak about it has to change. The way we look at putting naloxone in schools and colleges and malls has to be a first aid approach, that you're saving a life rather than anything else. And to that extent, you may have seen that recently, the president announced the budget, and one of the things that we're going to try to do is look at the stigmatizing language within our agencies and within across government. I mean, it's really important how we talk about something, the stigmatizing nature of those words. So I think that's one piece of education, and then it goes back to youth and prevention. And I think that's another aspect that we do have to, and our strategy will have a lot of those approaches in there to address. And I think it has to be beginning. I mean, you think about smoking. If people relapse on smoking and back and forth, they're not vilified for that. Yet we have a different approach towards this. So I do think it's going to take a while for the country and the nature across the country to understand it. But I think we're making progress. I want to be hopeful here. I think where we were 10 years ago, we're not today. I think there's a lot of bipartisan support for a lot of these activities, including harm reduction for the first time. It's not just something that we're doing in federal government. We have a bipartisan synthetic fentanyl opioid commission that has now endorsed all three versions of this policy. So it's important to take the gains and continue to move forward in an evidence-based and data-driven way.
Well, thank you so much to our panelists. This has been a very informative and compelling hour. So with that, let me thank Dr. Bakula, Dr. Blumenthal, and a special thanks to Dr. Gupta. And let me also acknowledge our sponsors for our two institutes, the USC Price School of Public Policy, the Keck School of Medicine of USC, the Dwork Peck School of Social Work, I'm not done yet, the School of Pharmacy, and also the Department of Population and Public Health Sciences and the Norris Cancer Center. So we're very interdisciplinary here at USC. Thank you for attending and have a good day.
Thank you.